I would like to thank myself for giving me the opportunity to speak at this conference. So, the title of this talk is Where do Genomic Classifiers Fit into the Pathway for ILD Diagnosis? Oh, we get to move this. So in regard to conflicts of interest, I have done some de minimis work with Veracyte. So this is our current last rendition of the guidelines algorithm as to how we diagnose idiopathic pulmonary fibrosis. And I would contend that, first let me say this, that a lot of good work has gone in to developing this. But for the love of St. Michael, if you have to have 2 MDDs to make the diagnosis, I think that's very, very challenging and very difficult. And in fact, Kevin Flaherty told me that most of the clinical networks centers don't have an MDD that they regularly use. So what happens out in the community? And I think it's important that many patients out in the community aren't going to come to our centers. So, unfortunately, people who live in East Wingnut, Mississippi do not like to come to the big city to get worked up. And so we want to be able to make these diagnoses earlier in patients as soon as possible so that we can get them started on effective therapies. So this is going to color my presentation to some degree. But these are the 2018 guidelines. And to your right there, we have that definite UIP pattern on CAT scan. And so those were pretty clear things there that we don't need any further diagnoses, and we've already gone over that. But most of the other recommendations on the left for the other categories of probable or indeterminate or whatnot are somewhat less defined. Their recommendations aren't as strong. And we have the option then to get further tissue in the diagnosis. And I think this has been talked about already. But to your left, with the VATS biopsy, you have a higher risk but a higher accuracy, and with the transbronchial biopsy, less so. And it still then, in the end, is very challenging at many places, including ours, to make a diagnosis of idiopathic pulmonary fibrosis. And here's some of the key points that HRCT misses 60% of cases with UIP if you're just going by that definite pathology. And as was discussed in the previous presentation, that there is risk, morbidity and mortality associated with obtaining a biopsy, and that there is, we're human, and there's difficulty or inter-observer variability in how we see things. And so what do we see in this picture here? So this was something that was shown to us by Jastra over 100 years ago. So how many see a rabbit? And how many see a duck? Right. And so we're all looking at the same picture here, but some of us see a rabbit and some of us see a duck. And sometimes when we're looking at CAT scans, is it probable or possible? To me, it's a rabbit or a duck sometimes. I don't have on speed Skype Dr. Lynch to call up and to look at the images with me, and most places don't in this regard. So, and it even depends upon the time of the year. If you look at the poll of the audience, in the springtime you see a bunny, in the fall time you're more likely to see a duck. So that's being human, all right? The other thing is, what do we bring with us into looking at an image, be it a CAT scan or a biopsy slide? So here's to your left, you can see this picture of Margaret Thatcher, the 10 years the leader of the Conservative Party and Prime Minister of the United Kingdom. And to the right is how the Labour Party saw her. Okay, as a monster. But we're looking at the same picture. It's the identical picture, okay? So it's what we're bringing. The other thing I'd like to bring is bias. So one of my least favorite things is to go down to radiology, look at a CAT scan, And the radiology resident says, well, tell me about the patient. And my answer is, I don't answer questions. You tell me what you see on the imaging. All right. So which is darker, A or B? The answer is they're the same. They're exactly the same shade. But your eye is being shaded, is being colored by the shading of what you're perceiving to be shading from that cylinder there. And I contend that it's probably the same thing if you go down to radiology and tell them what the clinical history is before they tell you what the pattern is. So this is just my perspective on things. So things are going to get a little bit messy here. So we're going to go into the genomic classifier then. And the idea of a genomic classifier is not at all new. So this is some work that was published 13, 14 years ago. And the authors for this were what I call the bees, Moises Selman and Annie Pardo. They would go around the country and the world and pollinate labs to be fruitful and productive. And this time they were working with Dr. Kaminsky. And they were able to differentiate using microarrays, and that was the technology of the day, the difference between IPF, NSIP, and hypersensitivity pneumonitis. So this is not something new in looking at tissue and being able to classify what the pattern is. So now we have new technology. We have next-generation sequencing, RNA-seq, and that's the topic of this talk. And so this is what's being developed by Veracyte, and the item or product is called the Envisia product, where you're collecting samples by transbronchial biopsy. Then you're getting this transcriptome data, which is exome enriched. Machine learning, AI, was used here. And then classification is done following that. And I just like to say in this paper that was published, I really like the way that they showed this. So at the top, they showed what the radiologist said, and at the bottom, what the pathologist said. And then they have a line of where the cutoff is for whether it's UIP or not UIP. And then the colored circles, or the red ones, are the ones where the MDD said that it was UIP or IPF. So it's very, very good showing of the data. And in the validation that was done of this then, after they taught the machine, then they had another cohort where they looked to validate this. And so the specificity was 88% and the sensitivity was 70%. And so the goal of this was to have the best specificity possible. So that's why it was selected where it was selected, and you've got your positive and negative predictive values shown here. And then they went further to do this study called the Catalyst study, where they looked at approximately 90 cases, and they showed these cases to 2 different MDDs. One case got to see the pathology only, and one MDD got to see the classifier only. And the agreement was 86% between those two. And that's pretty good, because if you take 7 different MDDs and show them the exact same 70 cases, the cap was 0.7. These are expert MDDs. So these are very good results. So we live in a rather European city. Some people say in New Orleans. It's probably the most European of the American cities. And in looking at a paper from Andreas Gunther, most of the biopsies that are getting done in Europe are cryo biopsies at this time. I happen to think we're the most northern Caribbean republic, but in any event, what we did here then was we combined cryo biopsy with a genomic classifier. And this was just all independently done with us. This was not industry sponsored. And what we wanted to see was, if we sequentially look at this cryo biopsy and genomic classifier, what would it do to the confidence of our MDDs that we put together in diagnosing ILD? And so, based upon the last talk, I should talk about the technique that Dr. Kerr used. in order to obtain these cryo biopsies. And you can see in the upper right panel, he's using a blocker. But we also published a paper recently where we're using bronchoscopic biopsy with ultrasound in order to help us locate where we want to go for the biopsy. And that was just recently published. So this is a cryobiopsy technology we use. So we looked at 24 patients above 40 years of age without what we'd call a definite pattern on UIP. Now remember, this study started before the white paper came out and was published. So there may be a little bit of confusion in regard to that. And the indication to get this biopsy was based upon a discussion between Dr. Kerr and myself. Here's the exclusion criteria, and by and large, we just excluded people that we thought were too sick in order to get a biopsy, or we thought that they might bleed. And so this is the design that we used, and we had the two MDDs, and we began by looking at the clinical and radiographic presentation of data, and then the MDDs made a diagnosis and said what their confidence was in the diagnosis. Then MDD1 got to look at the cryobiopsy results and then report on their diagnosis and confidence, and then sequentially the genomic classifier. MDD2, that was switched. They looked at the genomic classifier first, and then they looked at the cryobiopsy results after that, and then came to a final diagnosis. So the primary endpoint and secondary endpoints are shown here, but really we were looking for an increase in high confidence of the diagnosis. Now I'm showing these baseline characteristics just to show that they're very, very typical, but also because we have somewhat of a referral bias and pattern. I never get to see somebody who just coming in with a CAT scan with a definite UIP pattern and nothing else going on. They always seem to have had a dysrhythmia, so they're on sotalol or flecainide, and they've got a budgie named Bingo, and show me a house without mold in New Orleans, and I'll tell you it's not in New Orleans. So there's a lot of secondary things that would give me pause in the history that we were taking from the patients to say, that even though the pattern might be what we would call probable, there were some things in the history that made you wonder a little bit and put some doubt in my mind and in the minds of the MDD. So here's the proportion of high confidence diagnosis with MDD1, and in orange is just the CAT scan and the clinical history, and don't forget the examination. And then in yellow is adding the cryobiopsy, and then in green is adding the genomic classifier, and what that did to our confidence. And boxed here then is patients who had a radiologic pattern of a probable and those that were possible to the right. And then farthest to the right are those patients that we're looking at everything all together before we did any of this and said, this is not going to be IPF. And as you can see there, adding the genomic classifier in those cases didn't seem to help, but it sure did increase the confidence in those that would be considered probable or possible. MDD2 was a little bit different, and I sat in on both MDDs, and I was silent for MDD2. I just wanted to see what was going on. And then here you can see when they saw the genomic classifier first, let me go back, their confidence increased, but it wasn't statistically significant as it was with MDD1. When they added the cryobiopsy on top of that, they had a significant increase in confidence. So what was different between these two MDDs? One of the things that was different between them was they had a pathologist in MDD2 that just said it's UIP, whereas the pathologist in MDD1 said, this is difficult UIP, or this possibly may be UIP, and so it was that interpretation that we were getting from the pathologist that was affecting that in some way. The other thing is that MDD1 just happened to have people who were doing cryobiopsies. The other MDD was from an institution that was not doing cryobiopsies. And MDD1 happened to publish a number of papers with RNA-seq, and so felt really solid about next-generation sequencing data. We feel very confident in that, whereas MDD2 hadn't really had anybody who had been doing any of that kind of research. So that was somewhat revealing in the data. But if we look at overall agreement then, to your right then, between MDD1 and MDD2 on the diagnosis, in the end it was fairly similar, and the agreement between the genomic classifier was ever so slightly better than the agreement with the transbronchial biopsy, but not the cryo biopsy. But both of them were really pretty high in this regard. Now the caveat here is that we're talking about overall agreement and making a linkage where you have a variable which is the same. In other words, the MDD used this information in order to make that diagnosis. So that caveat has to be put in place. So our conclusions from the study then were that the diagnostic confidence of MDD increased significantly when a GC was added to a cryobiopsy. But we thought that GC perhaps alone could be employed when the HRCT is viewed as probable for UIP, or maybe even possible, in cases where the MDD decides that higher confidence is needed, the typical patient that we tend to see in referral rather than the straightforward case when there's nothing else in the history. But we also thought that the cryobiopsy was much more impactful for making the diagnosis, the final diagnosis, when the HRCT was inconsistent with UIP. So to summarize then, when doing a study, you're always thinking, is this going to change our practice? And we talked about this afterwards, and we thought that possibly so. So nothing changes farthest to your left. If your CAT scan says that it's definite for UIP, then you're done. If your CAT scan says it's probable for UIP, it depends upon the MDD and the clinical context of things. In other words, if there's nothing else in the history that's giving you any doubt and you've got a probable CAT scan based upon what Dr. Chung presented, then no biopsy or GC may be needed in those cases. If you have a practice like mine when there's always something going on that's giving me a little bit of doubt with a capital D, then the clinical context might suggest that I would need some more information to be more confident. And so at that time, we would do the genomic classifier just by itself, and then repeat the MDD after that. And then farther to the right then is those that are a little bit more indeterminate in that regard. And we're looking at the clinical context of someone where we're suspecting that it's possible IPF, and then we would do the genomic classifier. If there was clinically something else that was suggesting something other to the right, then in that instance, we would be more likely to do a combination of the cryobiopsy and genomic classifier. And for the alternative diagnosis, we really think it's sarcoidosis or organizing pneumonia based upon a CAT scan that just looks very atypical, we would just go with the cryobiopsy itself without the genomic classifier in that instance. So in closing, I'd like to quote Nobel Prize laureate in literature, who grew up on the Iron Range of Minnesota, Bobby Zimmerman, or better known as Bob Dylan. I think the times they are changing. Thank you for your attention.